Thanks so much, Sushil. Good morning, everyone. It's really nice to be back in New York. The title of my talk is How to Make Tricuspid TEER Reproducible and Teachable. These are my disclosures, and I would say that probably the revised title would be, Can Tricuspid TEER be as reproducible as M-TEER? This is a very similar case to what we saw this morning, an older lady with a flail, and I think we all know that throughout the world, in multiple labs, that we feel like we would have a high likelihood of having a successful M-TEER result in this kind of patient with resolution of MR, no significant procedural complications, a short hospital stay, a quick return to daily life, and most of us do it the same way with NPR or with advanced 3D echo technology as we approach. So how do we achieve that reproducibility in TEER? Well, I think there are three strategies that are most significant. The first is to standardize tricuspid imaging throughout your lab. I'm an echo lab director. We spent a lot of time standardizing how we approach TEER among all of us, sonographers and physicians, on TTE, on TEE, in 2D, and most importantly, in 3D. As we know, 80% of TEER is functional in etiology, and it's important before they leave the echo lab that you have diagnosed the etiology of their TEER. The ASC guidelines were published in 2017 for native valvular regurgitation, and in my opinion, they're incomplete. They've given us quantitative criteria for severe TEER, but as we know from our American and European colleagues, that the word severe TEER is probably too broad a definition. And this expansion of the severe grade to severe, massive, and torrential, the 5 grades of TEER, is what we use in our lab to explain tricuspid regurgitation. So a sample echo report in all of your labs would include an assessment of etiology, in this case, a 90-year-old man with atrial functional TEER, quantitative measures to grade on the 5-point scale, looking at both systolic flow reversal in the hepatic veins, and then looking at, other than just visual, assessments of RV cavity enlargement and RV systolic dysfunction. Once we've established severe TEER on transthoracic echo, the next step to reproducibility is mastering the 3 key views. TE view number 1 is the commissural view, what we call the working view for tricuspid valve. It's a 50 to 70 degree esophageal view where we can see the entire tricuspid valve, posterior anterior septal commissures, as well as the septal leaflet and back. You use 3D. Remember, X-plane is a form of 3D to basically create a line to allow you to identify leaflets. And this orientation, the posterior, anterior on one side, septal lateral on the other side, is what we use for all tricuspid valve interventions, whether it's TEER, TTVR, Evoke, Intrepid, valve-in-valve, anything that we do in the tricuspid space. The commissural view allows you to understand leaflets, their mobility, their lengths, coaptation gaps, and coaptation depths. It also allows you to understand the location and the severity of tricuspid regurgitation. The second key view is a transgastric view. I laugh because in the original MitraClip trials from the Everest data, we used to do transgastric, and then we were really excited we got away from it when 3D echo came, but now we're back in transgastric for tricuspid valve. The advantage of transgastric in 2D is it allows you to see the number of leaflets, their mobility, and the gaps. In 3D, it allows you to identify the anterior papillary muscle, and then anything posterior to that you know is going to be a posterior leaflet. It also helps you understand the origin and severity of TEER jets. These are not perfect circles, but rather very, very ellipsoid or very, very interestingly shaped TEER orifices. The next view to master is the 3D esophageal view. I call it the transgastric-like orientation. Other people call it the interventionalist view. We basically take the same transgastric view, and no matter where we do the 3D from, on TTE or TEE, we orient it with the aortic valve at 5 o'clock, the septum to the right of the view, and we've now recreated that transgastric view. And from this view, we do the majority of our diagnostic and cases in 3D MPR. We once again create this transgastric-like view by moving the blue plane down to the leaflet level. As you've heard, the newer version of Philips software, which they just upgraded in June, version 11, includes really enhanced frame rates and image resolution for 3D MPR. The other thing about 3D MPR is when you put color on, you can actually see the non-circular TEER orifice, and this becomes another thing that can be measured and quantified easily in cases and also in diagnosis, the 3D vena contracta or quantitative EROA, and this is just one example of it. 3D NPR is also useful when you move the blue plane to the annulus to do a measurement of annulus when we're assessing patients for TEER, not as much, but for tricuspid transcatheter interventions, definitely. The second thing is to optimize patient selection. Now, I'm not going to go into so much detail. I think Yoshi actually presented a lot of great slides on who are good candidates for TEER, only to say that the main driver, in my opinion, of TEER success is your septal leaflet length and your mobility. And this we interrogate in 2D and 3D, but TE really is the gold standard for those leaflet lengths. The second thing to measure is gaps, and these can be done in 2D, in esophageal or transgastric views. Remember, the same views that we're mastering, but they can also be done very easily and I think more accurately in 3D NPR when you line up your blue plane at the leaflet tips. You measure these gaps, and then that allows you to understand what are optimal cases with small coaptation gaps, good leaflet lengths and mobility, TR that's primarily in the anterior septal commissure, and no leads. What are more challenging cases, and when I think of challenging cases for TEER, I think of those with leads in them. In this case, a lead that's adherent to the posterior leaflet, but away from the anterior septal commissure. And then what are even more challenging cases? And you can see here there's a very large lead going through this very dilated tricuspid annulus. The septal leaflet is calcified and very, very restricted. And this may be a case that we would say is not a great TEER candidate. And in this particular situation, we ended up putting in EVOQUE. Although it's important to understand anatomic factors, septolateral gaps, jet locations, image quality, I think it's also very important to understand that these are not absolutes. So there are no absolute red, yellow, and green zone cases. What there are is anatomic features that suggest favorability, but it really depends a lot on your valve team experience. And as we gain more experience, we took on more challenging cases. Also have to set patient expectations for what they want, and then whether you have alternatives available. Are there other alternative transcatheter treatments that you can offer a patient? And then the final thing in making TEER reproducible is to develop a similar procedural workflow. As I said, we do this the same way every time. Anita, I actually took this line from one of your talks at TCT. The goal is to restore, not distort, leaflet coaptation in TEER. We had some examples of that when we were talking about our mitral clip case earlier on. The steps are the same: delivery system advancement, orientation and position, grasping leaflets, and then your pre-release and post-release assessment. The clipping strategy for TEER is based on old surgical techniques. So there's a strategy of bicuspidizing the tricuspid valve, which is usually achieved with multiple clips in the anterior septal location. And then there's sort of the clover-like strategy, which in TEER is achieved not by one stitch in the middle, by anterior septal clips and then posterior septal clips. All of this can be done very efficiently and reproducibly in 3D NPR. And I once again set up this same transgastric-like view, and then the entire procedure gets done this way. Again, I have the same orientation where this is the posterior part of the valve, anterior part, septal part, and lateral valve. And as I said, we do it the same way every time. I can see my clip arms here very, very clearly. I can use all of the features now of really advanced echo technology to make one view bigger, to see it more carefully if I need to. And then I can watch the clip arms go into the leaflet. I can make changes to orientation without going out of NPR. We do something very similar, even though 3D NPR has gotten a lot better with the newest upgrades. You still sometimes need a little bit more image resolution to see leaflets, and so we'll often switch to 3D X-plane for leaflet grasp. You can see leaflets laying on very nicely, and then the grippers coming down. In this case, we did one clip and sort of bicuspidized this valve. We assess our pre-release in both NPR as well as NPR with color. We can measure 3D vena contractors. We don't have a lot of TR here, so not a whole lot to measure. We assess mean gradient. Less than 3 is ideal. Usually in tricuspid regurgitation that's secondary, you have plenty of valve area to work with. You can measure tricuspid valve area, same as you do in mitral, and then also look at the hepatic veins. I watch release for mitral and TEER on 3D NPR. I can see here as we release that we have just a little bit more mobility on the anterior side than I may have liked, but really no significant difference in our tricuspid regurgitation. And this is one of the very few cases where we were able to just put one clip in for TR reduction. In my last 1 minute, I'll talk a little bit about ICE. I think ICE is very, very helpful. One of the key features of TEER is you're not just looking at anatomic and patient factors, but you're also looking at the quality of imaging. TEE can suffer from acoustic shadowing, particularly in patients that have had left-sided interventions. ICE is really advantageous because it's right next to the tricuspid valve, and it can really overcome a lot of the acoustic shadowing. One of the ways that we use ICE is we set up our arm orientation and position in either a 3D NPR or transgastric view, and then we turn on ICE for leaflet insertion and grasping. Also, by the way, lots of great enhancements in 3D ICE. Can also do the entire case in 3D ICE NPR, which we have done in patients with difficult TE imaging. So in conclusion, I think reproducibility in TEER is achievable. I would say that the key is to really gain expertise in 3D NPR, to evaluate the quality of your imaging while you are assessing the patient. So remember, it's the quality of the imaging, not the imager. Lots of great imagers out there, but lots of challenges with tricuspid imaging. You have your key views here. Patient selection should be matched to team experience. And I think we are all learning that ICE is a great supplement to these cases. Thank you.